So good afternoon, everyone. My name is Sneha Batra, and I'm going to talk about the risk factors of progressive myopia and accommodation anomalies among children in North Bengal. I do not have any financial interest in any of the products mentioned in this talk. So we all know that myopia is increasing not just in our Far East Asian countries, but increasing in India as well at a very rapid pace. We have a lot of myopia control options, as in low dose atropine, myopia control glasses, but we still see in our clinic every day that there are children who fail to respond to any of these treatment. So are we forgetting something very basic? In my paper today, I'm going to talk about risk factor management and the treatment of accommodation anomalies in these children. So in my study, children aged 6 to 16 years were taken from our myopia clinic over the past 15 months. And whom did we include? We included only the progressive myopes, that is those children who showed an increase of more than minus 0.5 diopters in the previous 1 year. They had not received any myopia control treatment before, and they did not have any other intraocular disease. Now, whatever is already done in our myopia clinic, the anterior segment examination, axial length measurement, cycloplegic refraction, dilated fundoscopy, along with this, we added two more factors. We did the risk factor assessment in the beginning, and we did an orthoptic assessment. So this was our questionnaire. This is the report which was made, and we saw the family history was there or not, or the time spent for near work, screen time, outdoor activities, and sunlight exposure. And among the orthoptic assessment, we did the cover test, near point of convergence and accommodation, accommodative facility, positive and negative relative accommodation, and the accommodative response by the meme method was checked. This is how the orthoptic testing is done by our optometrist in our myopia clinic. Now, then we divided it according to whether the children had no accommodative anomaly, a mild lag, or a significant lag, where the NPA along with the MAME was increased, or a lead of accommodation where the MAME was in the negative. Now coming to our results, girls and boys were almost equal, 53 to 47. The amount of myopia, most of them had moderate myopia between 3 to 6 diopters. Family history, at least 1/3 of the children had one parent myopic. And among the environmental factors, the total time spent for near work was 6.81 hours, along with additional 1.77 hours for digital devices, but for outdoor activities, only 46 minutes was given. And at least 46% had some kind of accommodation anomaly. Lead was more common than lag. So coming to the discussion, we all know that family history is important, but we always consider it to be a non-modifiable risk factor. But what we want to say is that myopic parents do not just pass on the genes, but they also create a myopogenic environment for their children. So if we can educate these parents, then we can actually make it into a partially modifiable risk factor. We also know from the studies from Singapore, Australia, India, big studies have been done which shows that exposure to green spaces, natural daylight, these are good for children. And more than 45 minutes of sustained near work is bad for children. And what do our children do? Despite knowing all this, 8.58 hours of indoor activity among children in North Bengal, compared to 46 minutes only of outdoor activities. And even when we are educating these parents, they say, my child's lifestyle is too busy. We are really sorry, but it would be difficult to change it because of the academic pressure of today's era. Are the accommodative anomalies important? Yes. They may be the cause, they may be the consequence of myopia, but it is there. And the lack of accommodation has already been stated to be an etiological factor due to the hyperopic defocus that it creates. So we should be correcting this. We should be finding it out in all the progressive myopes, and we should be trying to correct these so that their academic performance improves. And even the performance of low-dose atropine or the myopia control glasses has been shown to be affected, and the fast progressors are those who have these accommodation anomalies. So these should be corrected in each and every child who is attending a myopia clinic. So in our myopia clinic, we see the accommodative status and then go for the treatment. So it is important to educate the parents, change the lifestyle, and go for vision therapy if required before myopia control treatment. These are my references. Thank you very much.